Welcome, everybody. This is Levi Shapiro from M Health Israel. Today, we're having a debate about value-based care. Value-based care is the ongoing transition from fee-for-service to direct payment for outcomes. And we have two very esteemed and knowledgeable resources to address this debate. The debate is value-based care is not a panacea for the U.S. healthcare system. In favor of the proposition is Dr. Ron Razmi, a recovering cardiologist who now runs Zoi Capital. In opposition to the proposition is Dr. David Berger from SUNY University Downstate Hospital. He's the CEO there. He is also a surgical oncologist. Dr. Razmi, what's your thoughts? Is value-based care a panacea for the U.S. health system?
Well, Lavi, thank you, and great to be with both of you. And this concept of value-based care has been discussed now for almost 14 years, since 2010, with the passage of Affordable Care Act. I think it's a great concept. I think it's a great idea to manage patients proactively, to stay engaged with them outside of a clinical setting to improve their outcomes. However, my opposition to it, or my view of it as impractical, stems from the fact that we've been trying to do it for a long time, and we haven't made a lot of progress. And I saw firsthand why we haven't made a lot of progress. I ran a company that provided the technology for medical centers to do this effectively and efficiently. And we saw firsthand that these medical centers don't have enough staffing. They don't have the processes in place to start engaging with their patients outside of a clinical setting. And their economics right now is driven by a fee-for-service model. So if they switch drastically to a value-based model, it could affect their short-term economics. And that makes it hard for them to stay in business. And that is not really a formula for success when you're telling someone to do something that's against their short or medium-term economic interest, even if in the long term it's the right thing to do. So I think a combination of the fact that it's difficult to do, the incentives on the table to do it aren't enough, to get the medical centers to act, and also providers haven't really been trained in providing this kind of care. You could even argue you don't really have a lot of evidence from clinical trials that responding to blood pressures on a daily or weekly basis makes sense. So I think I'm for value, I'm for lowering cost. However, I look north and I see Canada. I look across the pond and I see Western European countries having achieved lower costs and better outcomes without putting this burden on their providers. And therefore, I question whether we're taking the right approach to reach the outcomes we need to reach. And we definitely need reform here, because we're an outlier when it comes to advanced nations. We spend more than anybody else, and we have the worst outcomes.
Yeah, Dr. Berger, it sounds like Dr. Razmi is saying value-based care is like communism. It's a beautiful concept, but very, very hard to actually realize. But you're running a hospital that's very focused on value-based care. So what's your input? What's your perspective?
So I would say value-based care is more like mom and apple pie than it is really about communism and like communism. And I say that because Ron already made the case for improving outcomes and decreasing costs, which essentially that's what value is. It's outcomes divided by cost. So either improve the outcomes or decrease the cost, you're improving value. I guess where we differ is how it is implemented. So first, the case is really strong that we need to change from fee-for-service. So in this country, we spend over 4.2 trillion, 17% of GDP. The costs are increasing. They're going to probably double within the next 10 years. And we're the only country where patients actually are going to bankruptcy because of medical costs. And despite those high costs, we lag the high income countries in terms of access, care processes, administrative efficiency, equity, outcomes. We have the highest infant mortality and the highest rate of avoidable deaths. The government in the United States has already set a goal in terms of implementation of value-based care. In fact, stating that all Medicare fee-for-service beneficiaries will be in some kind of value-based care arrangement by 2030, and 60% of Medicaid beneficiaries will be in care relationships with accountability for quality and total cost of care by 2030. So yes, this is not easy, and not all the systems are in place, but we've moved forward significantly in terms of what the systems are and what the systems necessary are to get them in place. So first, in 2009, the US passed the HITECH Act, which funded the adoption of electronic health records. In 2016, the Cures Act insisted on information sharing. In 2020, regulations were passed preventing information blocking between different entities and creating a standard for data sharing. Additionally, there has been examples of success in terms of implementing value-based care. And those systems include Kaiser and Intermountain, where we see higher cancer screening rates. We see 90% blood pressure control in patients. We see 75% adherence to medications in diabetic patients. And we've seen in these systems almost $300 million in savings just by tightly managing pharmacy. So there are examples that we can capitalize, that we can use as positive examples of how value-based care can be implemented successfully in this country. But there is really an imperative to improve outcomes and decrease costs.
Ron, it sounds easy. Outcomes, cost, Kaiser, Intermountain. Maybe value-based care is the panacea for the US health system.
Well, I think we need to separate whether we favor better outcomes and lower cost than value-based care, which is value-based care is tying payments to doctors to the patient's outcomes. And if a patient that had knee surgery does not follow instructions and their knee gets infected at home and they have to come in and be hospitalized for a week, if you're going to pay that doctor less for something that had nothing to do with him, then you have problems. And what I would say is the fact that Medicare has created goals. For example, in 2014, it was that by 2018, 50% of the payments to the providers would be tied to some kind of a value-based arrangement. That did not happen. They did not even get to 5%. So they've constantly moved the goalpost. Now it's 2030. I think that we have to come to realization that we're trying to achieve better value through an approach that's difficult to implement. David is right. There are examples of some progress and some success. However, they're isolated. They're limited to medical centers that have a lot of resources. And one of the things that we learned at Acupera, the years that we were doing this with medical centers, was it wasn't so much that they couldn't take a population of 5,000 or 8,000 and improve their blood pressure or focus on keeping heart failure patients out of the hospital. It was the fact that they couldn't do it at scale. To start managing a large population, which is how you move the needle on the statistics that David mentioned, you need to start engaging your staff in taking care of those patients, a large population of patients. And that's what we haven't been able to see is with limited resources, human resources, financial resources, technological resources, medical centers, they need to let go of the first 8,000 patients to start moving on to the next 8,000 patients. And what happens to the first 8,000 patients? Evidence clearly shows that after a while, they go back to their old habits when you don't have a high-touch approach with them. So the big point that I'm making here is this is going to be difficult to do at scale unless a lot of things change drastically. And we haven't seen that kind of drastic change yet in terms of payment forms and the provider behavior and health system economics. And may I say, patient behavior. Patients haven't shown. My favorite example is that we did some focus groups on this. Watching Real Housewives show scored much higher than logging into your portal and looking at your lab results and figuring out what screening tests are due and so forth. Engaging and managing your own health is anxiety provoking, it's uncomfortable, therefore it's behavior that hasn't been sticky.
Dr. Berger, can we do this if it's that hard?
So I think Ron and I agree on more points than we disagree. And, yes, this is really hard, but I'm going to paraphrase JFK when he talked about the moon landing. He said, we go to the moon not because it is easy, but because it is hard. Yes, this is hard. But the United States, in terms of what it pays for healthcare, is about to fall off a fiscal cliff. There is a huge need to change. I think we both agree that value is essential. We need to improve outcomes and we need to decrease costs. How we get there is up for debate. Some systems have been successful at it, and I mentioned two, and they are trying to spread their models. So Kaiser has partnered with Geisinger and built a company called Risant, which their goal is to spread the Kaiser model and to increase value-based care. Leaders from Intermountain, who built the value-based programs at Intermountain, have formed a private equity firm. They just bought a hospital system, Summa Health, and they're trying to test their value-based payment and care models in a larger system. So we do have examples of systems trying to spread their models. Are we there? Is it a panacea in the next 3 or 4 years? I doubt it, but we need to continue to strive to increase our outcomes and make outcomes better, decrease our cost, and how we get there. I think a lot of smart people don't necessarily have that answer right now.
I want to thank both of you for an excellent debate, and it's up to all of us. Thank you so much.
How long?